On behalf of the American Academy of Neurology and in collaboration with Neurology Today, it gives me great pleasure to introduce Captain Renee Pazdan. She's a neurologist and currently the medical director for TRICARE Overseas program with the Defense Health Agency. And for those of you not familiar, TRICARE is really the civilian component of our healthcare plan for service members. Did I get that kind of right?
Absolutely.
Excellent. So first of all, you're a member of the military. Thank you for your service. We very much appreciate it. You're also a graduate of the American Academy of Neurology's Women Leading in Neurology program. So I'd also love to hear how participating in that program may have kind of shaped your, your decisions, especially your decision to volunteer and do things at the Javits Center. So you live and practice in neurology in Colorado. You're from Chicago originally. I can hear a little bit of the accent still. How did you become involved in this project? It's the other side of the country, got a lot of stuff going on in the middle of a pandemic. You volunteered, you jumped at the chance. I'm on the Upper East Side of Manhattan, the other side of the Javits Center. It was just a terrible, terrible, terrible couple of months here, and you just jumped right in when you didn't have to. Why did you do it?
Certainly. So thank you so much. And really all of this does go back to kind of my educational history and my history with the military. And so as you can see, I'm a U.S. Public Health Service officer. We are a little known service of the uniformed services. We are about just over 6,000 officers strong and all public health service related. So there's under 1,000 physicians, nurses, health administrators, and we are actually part of the Department of Health and Human Services, but we work for multiple different agencies, so the NIH, CDC, and I've worked with the Department of Defense actually my entire career. My background goes to, I was an Army ROTC cadet at Duke University for undergrad, then I went to med school.
Great.
I trained at Walter Reed in Bethesda as a neurology resident and fellow in clinical neurophysiology. So I actually started my internship in 2001. As you can imagine, 2001 was quite a pivotal year in our country's history. I was actually on call as an intern on my internal medicine rotation.
Yep.
On September 11th, and literally watched the Pentagon burn from the 5th floor of Walter Reed. And so that was the start of my career.
Wow.
Was the start of my career in medicine and in the military. And things were really shaped by OIF, OEF, the wars in Iraq, Afghanistan, the increased understanding of traumatic brain injury. My first duty station after leaving Walter Reed in 2006 was at Landstuhl, Germany. So as you may or may not be aware, Landstuhl, Germany is where our large military hospital is in Europe, and that was really the first place that our service members are air-evac'd from CENTCOM, from theater, from Iraq and Afghanistan. And so while I was there is when TBI really became known, understood, and we would take busloads of, busloads of soldiers who had sustained concussions and more severe traumatic brain injuries, and then just were coming through theater. So that really shaped my career. And I was an Army medical officer at that time. I also had 3 young children at the time and just said, I don't know that a career in the Army in the peak of these wars is really the right thing for my family. And the mission of the Army is so important, and the Army Medical Corps is so important. And yet I was always drawn back to public health service. I had a mentor in residency who was a PHS officer who was on staff at Bethesda. And so I just kind of checked it out, and it just so happened that there was a memorandum of agreement with the Department of Defense and the Public Health Service to augment the DoD with providers who could take care of traumatic brain injury and psychological health conditions. And so it was a very natural time for me to switch services. And I took a position at Fort Carson here in Colorado, running the traumatic brain injury program at that time. And that was in 2010. And so really the PHS, our mission is to protect, promote, and advance the public health and safety of our nation. So, honestly, I feel so honored because there's no more lofty or important work, I believe. And so really it's been a perfect fit for me. So as a PHS officer, one of the things that we do is we deploy to federal disasters. Very commonly, that's hurricanes. We do oftentimes 2-week deployments to provide care in special needs shelters, medical shelters, for most often for hurricane relief, flood relief in Louisiana. And I've been part of a rapid deployment team since 2014. We also do deployments for like the unaccompanied minors mission, going down to the CBP border patrol stations to provide healthcare screenings and treatment, really serving a lot of vulnerable and susceptible populations. And so, as you can imagine, with the background of the Public Health Service, this was certainly a call to action for the public health. And we've been quite busy. Thousands of officers have deployed in all different types of settings, not just to Javits and other treatment facilities. We had officers in Detroit. They went out to DC. A team went out to Washington State. And ultimately, fortunately for them, some of them had very little work to do, which is, how you want your pandemic to be, quite boring. Right?
Yeah.
So we've also had officers set up testing sites. We've had officers do contact tracings and help communities with that. We've had officers go out to nursing home outbreaks. So really a very broad response and doing some important work, very dynamic, and the needs, as you know, are changing pretty quickly. So I got the call in March and had about the whole commission corps, all of the public health service officers are on alert right now. Any of us can get called to response really anywhere at this point in time. And I was called as part of my rapid deployment team to respond to New York. And I believe the initial call was to provide service for an 80-bed federal medical station for non-COVID patients. Well, as you can imagine, that quickly changed. I arrived in New York City on the 27th of March. It was a Friday. My flights out there, I believe there were about 10 people per flight. When I landed in JFK, it was literally middle of the day, or it was the evening, early evening. Yeah. And it was a ghost town. Yeah. I have photos because it's honestly, it's unbelievable.
It's eerie. Yeah.
It's unbelievable. It's really like something out of a movie. And so I started at the Javits Center on the 28th of March, that Saturday. So,
wow. And, I remember the planning process, and I, heard about the Javits Center, and, even in February when I have like a little group of friends that talk about the pandemic, mostly doctors actually, on text. And I said, this is going to be a tsunami. And in a month from now, I bet we're going to be in the text messages, going to be taking over the Javits Center because we're not going to have any space. And, people are, come on, whatever. And then someone mentioned about the Javits Center and like, wow, wait, that it really is happening. And it was supposed to be non-COVID patients. And then all of a sudden, obviously, I guess with the need, can you tell us a little bit about that? I mean, you guys are going in to set up a non-COVID facility. You have the place set up, you have some ICU beds, but when you guys were given the updated, plan of, wait a minute, actually, we're going to be a COVID hospital. What was that like?
Certainly, it was not surprising, okay. At least not to me and not to my medical counterparts, right? So okay. Just like in February, you were looking at the writing on the wall and knowing the math and the science, the writing was on the wall, right? And so in my current position as the medical director of TRICARE Overseas, I'm responsible for oversight of our contractor, International SOS, delivers that network care. And so I've been watching this since January, watching it affect Asia and then come over to Europe. And it was really the end of February. And I said, put on your seatbelts because we're ready. It's coming and we're in for a ride. And I actually told my boss, and my boss said, I can't believe China put up that hospital in a couple of days. We would never do anything like that. I said, Cindy, we would absolutely do this, and we will. Yeah. And in fairness, we didn't put up a brand new exterior walls, but we built a hospital out of a convention center. So once we got on site, I was one of 4 chief medical officers at the time. The other 3 were with the Army, the Department of Defense. Having worked really my entire career with the Army, it was a very comfortable and familiar situation. I spoke their language. I was a prior Army officer, and I had worked at Fort Carson for 9 years. And so not only did I speak their language, I actually knew several of the people who were there. And ironically, one of the other chief medical officers was an intern with me in 2001 as we watched the Pentagon burn.
Right. Oh,
September 11th. So we were, both ends of our careers were shaped by disasters where we were called to respond. So as Public Health Services, Department of Health and Human Services, we really had the initial lead and the responsibility for setting up a federal medical station. And as I mentioned, federal medical stations are usually in response to natural disasters such as hurricanes. And we typically provide care for those people who are displaced out of their homes. Maybe they're on oxygen at home, but now they have no power. Maybe they are diabetics, limited mobility. And so instead of going to a general medical shelter, they come to a federal medical station. And so that's the type of equipment and the type of medications and the type of care that we are used to providing as Public Health Service, as Department of Health and Human Services, oftentimes with DMAT teams, disaster medical assistance teams. That's the part that we brought to the response. The Department of Defense, now their role, right, is to set up field hospitals to take care of young, otherwise healthy soldiers who are injured in trauma and combat. Right. And so they were there with their skill set, and ultimately they were allowed to bring their equipment, particularly their ICU and the capabilities that came with that. So when we first got there, again, heading out the door, it was non-COVID 80 beds. We get there now, it's 250 beds, non-COVID. And we looked at the facility and we knew what was happening in the city. And we said, there's no way this is going to stay non-COVID very long. Yeah. And there are a number of factors that determined that it was non-COVID. And then really, when it became a COVID facility, my understanding is that was really made at the federal presidential level, having conversations and requests from the governor up to the president over to the Secretary of Defense to say, we need the Department of Defense, these soldiers, airmen, sailors who are responsible for taking care of the security of our nation, to provide civil assistance in this facility and put themselves at potential additional risk taking care of COVID patients. And then the good thing was, again, we were doing a non-COVID mission from the start, but we were always in the back of our heads planning that this is quite likely going to transition to a non-COVID mission.
Gotcha. Very, very, very cool. Interesting to hear your perspective. I mean, I saw what it was going on like from the back end and what the governor was saying and about the conversations that were happening, but then the conversations happened, and that's exactly it. Because, in some ways, we have to protect our troops, because that's a matter of national security. If our, like with the different, ships, one of the ships got infected, and, we have to be very careful because these are protect our country. So in some ways, that's a tough call to make that switch. It's not as easy as, oh, well, we need the help. We have other priorities and responsibilities too. So it's a tricky call.
Absolutely. And, all of that's above my pay grade. But what I knew going out there, and the promise that I made to my children, is that I told my kids as I left the door is that I'm going to do my very best to keep myself and all the members of my team safe.
Right.
And that's something that I could promise. And that is the promise that I held. And when we walked into the building and it was unclear how much PPE we had, what the PPE posture was going to be, how we were going to keep everybody safe in that type of an environment where you don't have negative pressure rooms, where you don't even have 4 hard walls and a door. My number one priority, first and foremost, was always the safety of our team. Right. And that is something that I feel I did make an impact on. I worked very closely with our safety officers. Our safety team was honestly one set of heroes of many on this mission. But even from the start, we knew that even as a non-COVID facility, we were not testing people to come into the Javits Center when they were non-COVID. Yeah. We were essentially saying, you do not have COVID symptoms, we don't know your status. So I like to call it asymptomatic COVID unknown.
Yeah.
And so we really set up our posture to just assume that our patients could have COVID. And that being said, that was the right answer in the end. And we were able to support that. We were able to make our leaders and resource people know that we needed that level of PPE, and we were able to keep our team quite safe.
That's great. Speaking of safety and just the whole the whole situation, just, trying to picture myself, we were inundated. My wife was, I'll use the term redeployed, covering Sloan Kettering and Slittering Lower Manhattan and Weill Cornell, gigantic hospitals. She was like covering ophthalmology for like multiple gigantic, it was just made no sense, but we had to all do it. So she was redeployed, and just like, it's different when you're being redeployed and you're taking care of maybe non-COVID, some COVID, and maybe the service in some ways were a little lighter, because we were something, less strokes, less heart attacks, less eye issues, that kind of thing. But I mean, you were literally like surrounded by, I don't know if it was 1,000, but it was a lot of patients that were seen at Javits that literally all had COVID, and you're sitting there in your mask. Like, what was it like? Just like a silly question, but to be surrounded in such a large space with a roof over it, also, so you're in an enclosed yet large space, being surrounded by COVID patients.
That's a great question. I would say that my anxiety going into the situation was greater than once I was on the ground and we could actually take control and set up some of those safety things, right? So again, my role as chief medical officer was predominantly from the command standpoint. I was on the 4th floor where we were making kind of clinical leadership decisions, but I made it a routine practice to go down to the safety floor and to interact with our clinicians and to interact with our patients. Once we knew that we had enough PPEs, that I wasn't just working it, right? But we had an intensivist who was Major Sean Shirley, was another unsung hero of this operation. And I spent a morning rounding with him, learning how he was taking care of and working with other non-intensivists to provide this kind of expanded care. So I would say that it was more terrifying on the front end not knowing than actually doing it, because once we were able to not just provide our PPE posture that assured us a level of safety, we put in some administrative controls. We went from 12-hour shifts for physicians to 8-hour shifts. We worked hard to give individuals breaks to come off of the floor. All of that's imperfect, and depending on how many admissions there were that day, et cetera. We had a throughput of donning and doffing. And so you don't just go into the patient floor area. Literally, that you walk through a donning and doffing where you had surgical techs who would walk you through step by step. Very important going in, and particularly important coming out when you're tired, fatigued, just want to get off, and you have a higher risk of exposing yourself. And so those additional controls are really, like I said, the safety officers were unsung heroes of this mission, but they did those things to keep us safe. They worked with facilities to reverse the air circulation. Was it negative pressure? No, but at least they did that. They added, HEPA filters. And so it was really multidimensional. People think, okay, a hospital, doctors and nurses, well, there's really so many more components. We had CDC infection disease doctors on site. We had the New York City and New York State Department of Health infection disease experts on site providing input and insight. And so really, together as a team, we were able to provide care to 1,095 patients total. Our peak day, we had, I believe, 452 patients in the facility. I believe at that time we were the 9th largest hospitalized collection of patients in New York City out of 55 hospitals, network hospitals. Again, now we did, we in fairness, I guess, so to speak, cherry picked our patients. What we were looking for was to make sure that we were attempting to provide care for those who are on the back end of their trajectory, recognizing that even so, it wasn't going to be perfect. And we guesstimated about 10% of our patients would potentially crash into the ICU. And we had a 48-bed ICU where those individuals were cared for.
Great. So that's you can never predict even after they're over the 10, 12, 14 day, okay, we're in the clear. No, nope. This
really unpredictable.
Yeah, this virus has like a mind of its own. And it comes in stages, and then it comes back, and and it's not the virus anymore. It's a cytokine storm. We won't get into the sciencey part, but you had to be ready for anything.
But so I was there for 30 days on site from March 27th. I got.
Did you get any pizza or bagels while you were there at least?
All of it, yes.
Okay, just making sure. Good.
Absolutely. We and that was the other thing. So we were able to eat on the economy. We took takeout from the local areas, which is
Great.
great. And recognizing that if you do the right things, protect yourself, wear a mask, hand sanitize, stay away from people,
Yeah.
you can stay safe.
Yeah.
The New York City was a ghost town that Saturday. The very first day, the 28th, leaving the Javits Center, we crossed the street against the red light, and there was not a car in sight on a Saturday night. And
Completely correct. And I live in the Upper East Side, and I would walk to Central Park, and it's like 3:00 in the morning, but it's noon. And it's like, you feel like there's something wrong here. Like it feels like in July 4th weekend, actually, it's pretty hot in the city and the city empties out. It was like quieter than that, like at all times. So, you get an eerie feeling.
Very eerie. It was very eerie. And it was already starting to feel, I think, a little bit different. I left 30 days later. So half of my team stayed on for another 6 days until the Javits closed. Sure. And we turned it back over to the state.
That's great. So I got a couple more questions for you. Thankfully, COVID cases are declining. Deaths are, very, very low. We're actually about to, hit phase 2, right around now of the opening plan. I see people on the streets. It's just starting to, feel better. We're all masked and we're all very careful, and we've learned a lot and being very, very careful. I think I don't want to equate this to a battlefield or a war situation, with PTS and that. It's a different degree, different type. But I think a lot of New Yorkers who literally lived in Manhattan or in Queens, Elmhurst was just terribly hard hit. Other places, it's a little bit of some sort of elements of post-traumatic stress. Like people are being really careful. I hear an ambulance from we were hearing ambulances every 3 to 4 minutes during the peak. I live right next to the hospital, but I hear an ambulance in my apartment now, and it takes me back, and I get a little skittish or whatever. And a lot of people are leaving the city. So things have been tricky, I'll put it that way, but we've learned, and we're trying to do as best as we can. When you hear about the declining cases, I'm sure that makes you feel better, but we're also, we're still in the first wave, I guess is how I see it. And we're having another, I think, a peak in our first wave. But when you hear about this second wave that may be coming in the fall, it freaks me out. Just to even think that could actually happen again. But do you think we'll see numbers high like this again? You don't have to comment on that if you don't want to, but if we do see numbers that high, do you think we're going to have these types of emergency spaces open up again in different places? And what did you learn from doing so? I'm sure it was not, hindsight is 2020. What did you learn in those 30 days in New York to make a potential next phase of emergency places go a little bit more smooth?
Absolutely. So I am not going to predict whether or not there's a second wave or how big it's going to be. I think we need to be prepared for that. And I can tell you that certainly the Department of Health and Human Services, ASPR, the Public Health Service is preparing. They are taking lessons learned absolutely from the Javits Center and from other responses across the country. The ASPR Tracy is a website. I shared with you that interview that was done with myself and the DMAT team and other people from ASPR. They essentially have an alternate care site toolkit that's being updated and informed by the information that we had from the Javits Center. Again, the Javits Center is unique in that it took the greatest number of patients from any of these sites across the country. And so we do need to learn from that, because the response was fast, but it will be faster the next time. My understanding is that the city and the state is maintaining some capability at the Javits Center such that it can be readily opened up, and it will be faster because we have infrastructure in place. We have policies and procedures. We have people who have captured the essence of how things were done and what was needed. Just a simple thing, we knew at the end of March already that there was a high thrombotic component of this disease.
Right.
That's not a big, anticoagulants are not a big part of our federal medical station cash, but we needed to get that on order early. Well, now it's already in the pre-planning stages, right? The vast amount of oxygen that's required to support these patients. We already know that. We understand that you can't just put a bunch of tanks into a building, otherwise it's a fire hazard. And so there's oxygen that's plumbed in, for example. And the information that we learned is not just helping New York City, it's really being captured by the federal government and shared widely and available widely, so that the response is faster, better, more nimble, and adaptable, because, as we've learned, things are unpredictable, and we have to be flexible and nimble in order to respond to the situation of the moment.
Great. And just for those people that are watching, ASPR stands for the Assistant Secretary for Preparedness and Response. And, I guess I would hope that these types of organizations exist within the various intricacies of our government, but I actually didn't really know what it was, and I did some Googling and read about it a little bit. It's great that the manuals are being updated and we have a revised playbook. And I agree. I'm not going to predict necessarily if there's going to be spikes or this or bigger, like who knows, and all that kind of stuff. But it better be a good idea to get prepared. So I'm glad we're there.
Absolutely. And I want to just put out a plug for neurologists, because I think we think about disaster response with emergency medicine, maybe family practice, primary care. But really, as neurologists, we are very adept at dealing with complex problems without clear solutions, right. And solving things with a lot of uncertainties. And I believe we're strong communicators. And so many of those things poise us well to be put in these situations of redeployment. I've had several neurology colleagues in New York City who are redeployed to provide general medical care or internal medical care. And we're fast learners, and we can work in these teams and provide surge capacity, one other thing that I've done in my personal community is I've reached out to our school superintendent and just said, let me know if I can be of assistance in how we reopen our schools safely. I don't have all the answers. I can review scientific literature, provide some input into, considerations on safer ways to do this. And so that's something that I put out as a charge to all neurologists, in that we have a skill set that's adaptable outside of just neurologic disease and injury.
Yeah. And that's one of the benefits. You and I both did intern year the same year. I remember vividly it was like a cell phone pager thing that came apart, and I'm just like, a plane hit the trade center. That's terrible. What a terrible thing. And then of course, we realized what happened. So we did internship the same year, and we actually learned medicine. Neurology used to be a subspecialty of medicine. And like for stroke care, for most of neurology, there's a lot of medicine. So I think neurologists were very versatile. Many of us were redeployed. I think like almost 20% of our department was either in the ER or in the ICUs, or, some was answering phones, workforce health and safety. But I agree. I think neurologists by nature, understanding complex problems, understanding how to approach something in a very precise or maybe tactical way, if that's a good word in this sense. So I totally agree. One last question that I think is really important. So the American Academy of Neurology tries to provide as much as possible for our members. One of the things that I participated in a long time ago was one of the leadership development programs. I participated in Neurology on the Hill to try to push forward policy changes and for advocacy. But you participated in the AAN's Women Leading in Neurology program, and I'd just really love to, how did that program potentially have any sorts of influence either on your career trajectory or even potentially the decision and some of the decisions you made to even participate at the Javits Center?
Absolutely. The Women Leading in Neurology program was pivotal for me personally and professionally. It was after that program that I was inspired to apply for my current position as the medical director for TRICARE overseas. You think, well, what does a neurologist know about medicine overseas, kind of all medicine, right? But again, it goes back to the thought process and the way that we approach problems. And then, so my background and experience in neurology and taking care of particularly traumatic brain injury and post-traumatic stress disorder, complex patients, combined with my deployment experience as a PHS officer, I said, you know what, this is something that I can do and that I'm interested in, and I'm going to put my name out there and put my application in. Whereas I'm not sure that I would have done that without actually I should say, I know that I would not have done that without the neurology. It gave me that confidence. It helped me think about my skill set in a different way. And then when I got to the Javits Center, as I said, I wasn't even clear what my role would be. And my role is different on deployments. The last deployment to North Carolina, instead of being in a leadership position, they needed more docs. So I was a doc, and really they were short on nurses. So I was doing predominantly like CNA work, and that was what was needed. And so that's what I did. So when I got to Javits and realized that I was the lead of the 4 chief medical officers at the start, I said, wow, well, that was unexpected. All right, let's do this. Right? And having done the Women Leading in Neurology program, I recognized that I could do it, and that I brought that skill set to the table. I had the confidence, the competence. I didn't have all the answers, but I had, there was an amazing amount of skill set and knowledge and expertise that came to the table at Javits. And my role was to integrate, to pull that together, and to make the best decisions I could in a collaborative fashion. And having gone through the Women Leading in Neurology program, I was better able to understand that I could do that, and to have the skill set in order to accomplish that mission. And then also realizing that once we became operational after about a week, 10 days in, it was really more of a Department of Defense run facility. And so that at that point, I personally took a step back, and there was a DOD officer who kind of took the lead as the lead chief medical officer. And it was very comfortable to do that. And it was really many of the skills that I learned about my individual strengths, and also working in a team from that Women Leading in Neurology program that helped set me up for success.
That's awesome. That is really great to hear. The AAN invests a lot in these programs, and, we try to track metrics, and we try to track, what bills were passed or what positions people have, but there's no true, perfect tracking metric or surrogate. This is quite a surrogate marker. I'll put it that way. So I think this speaks to the success. So first of all, thank you for your leadership. Thank you for your service. And thanks for coming to New York and helping a brother out. This is a tough time. So we appreciate it so much.
Thank you. And I just want to put in one last plug for the public health service and the services in general for individuals. As as neurologists look at their career choices, there are many opportunities for neurologists in the Department of Defense, and particularly in the public health service. There's even an opening at Fort Bragg to do work in their Intrepid Spirit, taking care of TBI patients. And so if anybody's interested, please contact me. Look at usphs.gov. It is an amazing opportunity. And I have learned so much in situations I never would have expected myself in. So it's just a different career path, and a very, very rewarding one.
Yep. That's awesome. You're still a clinical neurologist 1 day a week? Is that kind of?
Yeah. I still practice it at Fort Carson 1 day a week. Try and do a little bit of sleep medicine, EMG, EEG, TBI. So, kind of filling in gaps wherever I can.
Yeah, so. I understand. Great. Renee, really enjoyed chatting with you. And thanks again so much for everything you've done.
Outstanding. Thank you so much for the opportunity.
Okay. Take care. Thanks.